Share your journey from medical training to building a private medical practice.
I'm sure. I mean, after 5 years at the med school, like any doctor, some people do six. I did my house officer year, what used to be called, when we're doctors with L plates before the GMC takes us on. And that was all, I did that all in one place, actually, at the Homerton Hospital in Hackney, which is a great hospital. Now it calls itself a university hospital. Unusually, actually, because I went to medical school with the intention of becoming a psychiatrist. I knew very early on that that's what I wanted to do. And what used to be an opportunity, things have changed a great deal now. But back in the day, as old as I now am, you used to have to do 6 months general surgery, 6 months general medicine, and that's what was necessary for you to gain your registration. But there were what were called 12-month jobs, which gave you the opportunity to spend 4 months in each of those, with the opportunity to spend 4 months working in a separate medical specialty, and there was the availability at Homerton to spend 12 months solidly there rather than moving to another hospital and doing 4 months of medicine and surgery and 4 months of psychiatry. So I did that between my medicine and surgical jobs, and it was a pretty fantastic year. When I became a consultant, that slightly confused things because I was still running that ECT service. And so I wasn't technically speaking a junior, but started seeing occasional patients independently. And it was around about that time that I then started working at the Nightingale Hospital, where we had started admitting patients occasionally as well. And in the earlier stages, I was only looking after inpatients. But as things progressed, I began seeing private patients evenings, and it rather expanded from there. Compared to where things are now, I mean, it's chalk and cheese. I'm not there. I'm there one evening a week, but I'm there. Well, I'm either there geographically or working remotely 5 days a week. So things are very different. And, the extent of the responsibility that for patients is rather greater just based upon the sheer number. But it's a full-time endeavor now.
What was the biggest misconceptions that you had about growing a paramedical practice early on?
I think I probably assumed to some degree that it would be easy, that it would be something that would be organic in its own right, and grow. I think so much has changed. And I think this is probably the major misapprehension because it's difficult to predict the future, but so much has changed since I became a consultant in 2010. I think that the environment of working privately has changed. I think the water has become quite muddied because it's so heavily populated by doctors now. And there's been a particular explosion actually since the pandemic. I think that has not only influenced the way in which private services are accessed, but it has also influenced the involvement of insurers, who I think have become progressively more controlling in a way that I don't think they were actually in 2010, certainly weren't previously, both of doctors, but also patients that are their clients, with the latter perhaps being more understandable. So I think that, the way in which things have progressed have been largely influenced by an environment, and that's when it starts becoming kind of slightly mucky because it's a marketplace. And as a doctor, I don't like that concept at all. But I think I had slightly assumed that it's something that would grow. I think partly because I'd worked with people who had been working in the private sector for 30, 40 years. And the old guard necessarily approached private practice in a very different way, and things did grow organically. I think that now it is rather difficult. I think primarily because of that difference. And I think particularly as a patient, and I've had to look for private consultations myself and my family, that actually finding the right person, I think, is really difficult. Because seeing the wood for the trees is almost impossible with just the sheer glut of people who are now occupying that space. So I think that's probably the major thing that's changed.
What skills do you think private consultants need today that medical training doesn't prepare you for?
I think almost anything and everything that comes to being it comes from being self-employed. I was certainly unprepared for it. I think that, one tends to approach it in a slightly clumsy way to start. I think, you can be too over-prepared for it. You can try to organize yourself too much for it. But I think that the kind of the general system and expectations that one has, that, you need a system set up for actually thinking about how you charge people for your time. I think that there is a very limited understanding amongst doctors as to how to charge for their time, or indeed how to value it. And I'm afraid that partly comes from not only teaching and training at medical school. I think it also comes from the way in which people are, broadly speaking, treated within the NHS, that you are a commodity, but not a commodity that is often terribly valued. So when it comes to actually evaluating your own time and your skill set, I think that is very difficult and feels very foreign. And I kind of appreciate that sense in one respect, that it should be alien to a doctor, because I think that it needs to be a secondary consideration. Otherwise, we're just not doing what we're doing. And if the money is at the forefront of this, I think that's very problematic. Properly value your time and evaluate it from a business perspective. knowing how to deal with the logistics and the practicalities that follow that, and how that then actually places you within that overly occupied environment in which you're practicing. And although it feels foreign, trying to bring the two together has to be done. Otherwise, it's never going to work. It's never going to take off.
At what point in your consultant career did you realize I need to take my private practice more seriously as a business, not just clinically?
I think part of the problem that arises is that, or certainly part of the problem that I face is that I necessarily occupy my time clinically. That is, I mean, it goes back to what I was saying about the sort of the filthy lucre. That the financial side of it doesn't enter into my consciousness when I'm seeing patients, and I'm, with a full clinic, I'm busy. I'm with a full clinic 5 days a week. I'm busy with a lot of patients. I'm busy with a lot of paperwork. I'm busy with a lot of trying to communicate and actually oftentimes bring a lot of other people to the table to communicate effectively and efficiently about a patient's particular presentation and how best to help them and to drive their recovery forward. So having to have a one eye on a diary and be certain that there is, patient throughput, that there are enough new referrals to continuously support that clinic, I think is really difficult. And I think that there is a notion sometimes that, if you've got a gap in the diary, well, that's a bit of breathing space. And I think that as doctors, sometimes it's gratefully received. But the problem is that has an exponential effect. And keeping an eye on that rather than being able to keep an eye directly on my clinical practice. And it's a problem that I know affects my colleagues as well. I think it's a problem that affects private hospitals as well, because I wanted my eyes to be on the patients and the patients that were in front of me in the moment, not the patients that were potentially going to be in front of me in 2, 3, 4 weeks' time. And that I wanted to adjust that focus because my prospective focus on the future just wasn't constructive or helpful. It was just a source of concern.
Why do you think some excellent consultants and clinicians struggle privately while others are thriving?
I think that's really difficult to answer. I think it's really difficult to answer because, oftentimes being able to set up in private practice arguably requires less than obtaining a consultancy in the NHS because you're setting up independently. I think that, you can be the best specialist in the world. I don't know that everybody is necessarily going to gel with the way that one needs to work if one is working in the private sector. And that's probably true for a great number of professions rather than medicine alone. I think that one of the difficulties that arises within that context is that you're very exposed and you're the primary source that is responsible for what happens within that private practice, both in terms of patient throughput, but also in terms of problems that might arise, that you're not going to be working within the context of having junior members of staff or allied members of staff. There isn't a trust built around you that will actually shield you quite a lot from problems that might or might not arise. And so I think that can be quite a difficult environment in which to operate. I think that knowing that you are good at something and having the reassurance that other people agree with you on that is one step, but it doesn't necessarily mean that people outside of the medical sphere know that you are good at that.
Mm-hmm. How do you see AI changing private medical practice over the next 3 to 5 years?
Right. Well, my take on AI at the moment is that it's interesting, not exciting. And the reason I don't think it's exciting is I just don't think it's applicable. I've come across huge problems with it, not through my own use of it, but because of the exposure that patients have had of it. And it comes up frequently as a point of discussion that patients will undoubtedly have looked up what's wrong with them, particularly before they're going to see somebody privately and paying for it rather than being seen on the NHS. And they will have a very set idea as a consequence of that. I think that AI has a role to play, but a subservient one. I think that the issue, certainly at the moment, is that AI, ChatGPT, Google AI, whatever, is often wrong. And patients have been to see me and said, well, this is wrong, although the diagnosis might be right, the treatment path just does not fit them. And I think that the difficulty, not necessarily a difficulty, but I think where AI falls down in terms of attempting to be a clinician is that AI has the experience of an awful lot that is written online, but it has no fundamental experience in the real world. And that is something that is very difficult to feed forward or develop on a more organic basis when it also needs to be contextualized back into the person sitting in front of you. So the role that AI has to play on a directly clinical basis, I'm deeply suspicious of. And I worry, actually, I do think it's a significant concern that there is in some way an assumption that might be appropriate, because I think we're a long way off that. And indeed, whether or not it'll ever be possible is another matter.
What would you tell a consultant who's just starting their private practice and private work now?
Don't expect to walk into a private practice. If you think that you can walk out of an NHS job, even if you're walking out of it just at 5 o'clock before going back the next day, and that you can walk directly into a fully fledged practice in your name, you need to go back to the drawing board, because like anything, it is something that needs to be worked at and something that needs to be earned. And becoming a consultant is not sufficient in its own right to determine that there will be a private practice waiting for you. I think that assumption, and I've seen it with a number of colleagues who've been kind of disappointed, and the expectation was slightly different from the reality. I think that would probably be my best advice, that forewarned is forearmed. I think that also, having a think about how private practice might actually differ from your experience of medicine, because the medicine is one side of it, and the experience is going to be very different as a consequence. I'm busier than I ever have been during my professional career, not because I have so many patients. I'm busier than I ever have been because my responsibility to those patients is far greater than it ever was in the NHS. And because the clerical work, the bureaucracy that surrounds me as a consequence of that is necessarily much, much greater. So I think that the disparity and what it is that separates what you will be doing privately from what you'll be doing in the NHS, because the medicine, fundamentally, that doesn't change, but it's everything else around that. And training through the NHS, you're provided with a secretary, there are systems in place, and they are, near as damn it, they're all the same. They're all the same. It doesn't matter which trust you've worked in, which hospital, and some of them may be worse than others, some of them may be better than others, but the system that is in place is all the same. And as you move from job to job to job, as we all do frequently during the course of our training, the one thing that doesn't change is the system that supports you doing the thing that you're trained to do. The thing that you're trained to do will not change. It's everything else surrounding that that will. You are entering into a system that is different by virtue of the fact that the infrastructure, although it might be there depending upon whom you're working with or indeed working for, but the infrastructure is otherwise not there. You are free floating.
And then my last question is what excites you the most about the future of private medicine in the UK?
I don't know that it excites me yet, but I think it has the potential to, which is that the history of medicine in the UK is dominated by the NHS over the course of the past 70 odd years. But the NHS was set up within broadly speaking, a private medical system. I think that rebalancing where things lie, I think has the potential to be quite exciting. I think the capacity potentially for private practice to exist within its own right, as I think it should, without it being seen in some ways an impingement upon the NHS. Now, in order for that to be the case, there needs to be a balance. That you can't have everybody leaving the NHS to come and work privately, because it needs to be supported. I think it would be hard pushed to find a doctor that doesn't think that it should be. But it feels at the moment, I think, a little bit too much like there is a battle line that is drawn between the two, and I just do not understand it. I find that communication with primary care, who are constantly overloaded at the moment, is increasingly being supported by the British Medical Association, not to take on additional work from private consultations, so consultations with private clinicians, and that concerns me. I think that there are bridges to be rebuilt, and I think a greater understanding to be developed that actually the private sector not only complements but can assist the NHS and unburden it. And I think that this manner in which it's being proposed as being something that's competitive is problematic. I think that the other thing that I find more exciting on a clinical basis, which is perhaps rather more established already, is the possibility for further research to be conducted in conjunction with private enterprise as a whole. That's often seen as a bit of a dirty word because it often means drug companies, but the drug companies have been involved in their own research for donkey's years, and that's not going to change. What I'm talking about is the collaboration between private equity funding the research and the institutions conducting the research, as well as research being seen as being possible within research centres within the private sector. I think that one area in which that's been particularly pronounced has been in the development of the more recent Alzheimer's drugs, for example, and the speed with which that's been developed has been quite exciting in terms of the trials that have been conducted. And arguably within that context, within those particular disorders, it's one of the biggest jumps, one of the biggest advances that we've seen, having previously had medicines that perhaps keep things within a status quo and slow decline. We're actually seeing things that have the potential to halt it. So that's enormous. And I think that, we've seen this in a variety of different settings. It's happening, I think, with greater frequency. The major research councils actually increasingly have started to encourage it. And I think that research, rather than just clinical medicine, I think has the potential to prove a very exciting breeding ground for future work to be conducted within the UK, within the private sector, but conjointly with the more typical medical institutions within the public sector, not just the NHS, but also universities, who are also absolutely key because it's where the academic figureheads tend to be. So I think that's probably the area that I think the private sector as a whole, within the context of medicine, presents the greatest or the most exciting opportunities moving forward.